Hello, my name is Dr. Adam Van Huis. I am a gastroenterology and hepatology fellow at Froedtert and the Medical College of Wisconsin. With the mentorship of Dr. Veronica Loy, I'd like to share with you a brief overview of the factors that contribute to healthcare disparities among Black patients with hepatocellular carcinoma, also known as HCC. HCC is the most common primary liver cancer, and in the vast majority of cases, it develops in patients with underlying cirrhosis. Cirrhosis is caused by long-term injury to the liver, leading to fibrosis and scarring. Historically, the most common risk factors for developing cirrhosis were chronic viral hepatitis, specifically hepatitis C, and long-term heavy alcohol use. However, recently, non-alcoholic steatohepatitis has become increasingly responsible for causing cirrhosis. In this disease, the buildup of fat in the liver over time leads to inflammation and damage, ultimately causing cirrhosis. When HCC develops, patients can be treated in a variety of ways depending on the stage of the cancer. If the cancer is localized to a small part of the liver, a partial hepatectomy, liver-directed therapy, or liver transplant can be performed. If the cancer has grown too large or spread to other areas of the body, systemic chemotherapy or immunotherapy may be used. So what factors contribute to worse outcomes in Black patients with HCC? The answer to this question highlights some long-standing disparities that exist throughout healthcare. I've grouped these factors into 4 different categories, however, many of them are interrelated. The first category is medical risk factors. Black patients are disproportionately affected by metabolic syndrome, have the highest incidence of chronic hepatitis B and C infection, and recent immigrants may have potential exposure to aflatoxin B1. In terms of diagnosis and treatment, disparities begin with the lack of treatment with antiviral medications for chronic viral hepatitis. Once cirrhosis develops, Black patients undergo lower rates of surveillance for HCC. In addition, they are less likely to be treated with liver-directed therapy, have partial hepatectomy performed, and be referred to and undergo liver transplantation. In those who do receive treatment, there is worse survival for Black patients regardless if they received medical or surgical treatment. Then, there are socioeconomic factors that contribute to worse outcomes. Black patients are more likely to have decreased access to cancer and transplant care. Studies have shown that lack of insurance or public insurance, lower median income or unemployment, and lower level of education all contribute to disparities in liver transplant outcomes. Finally, there may be a small role for biological differences. Black patients have a slower progression to cirrhosis, which necessitates longer commitment to HCC surveillance. Black patients also present with cancer at a younger age and with more advanced disease, which could represent differences in tumor biology. I hope you found this review to be educational. We in the medical community will continue to work tirelessly until we close gaps in healthcare disparities.